Good afternoon, ladies and gentlemen, and boys and girls. It's my pleasure to introduce to you Professor Stephan Windecker. He is a physician-in-chief and director of cardiology at Department of Cardiology, Swiss Cardiovascular Center, Bern in Switzerland. His main interests are interventions in coronary devices, structural heart diseases, and TAVR, to name a few. And he's intensely involved in medical education and research. So it's my great pleasure to welcome you, Professor Stephan. I hope you had a comfortable journey from your place to Mumbai, and welcome to India and CSI Mumbai.
Thank you very much for the kind invitation. It's an honor for me to contribute to CSI India 2018, and it's a pleasure to contribute to your conference.
Yeah. Is the first time you have come to India or Mumbai?
Actually, I have been several times in India, but it's the first time that I attend the CSI conference.
Thank you very much. And to start the ball rolling, we know that coronary physiology guided coronary interventions have become the standard practice now. And we know that FFR was given a label of class 1A indication in stable coronary artery disease patients with intermediate coronary artery lesions. But still, the uptake is very low. Very few cardiologists practice FFR or physiology guided intervention. So I'd like to say a few words in introduction to coronary physiology, and then tell us why this uptake is so low.
Thank you. I think these are two important questions. I think, as you mentioned, during the past 2 decades, really we have seen the introduction of physiology-guided revascularization, which built on several studies in order to build evidence, which then led to a class 1A recommendation, both in the European and in the US guidelines. And I think what we need to recognize is that all these studies and evidence building took considerable time. So first, there was the defer study in order to establish that actually within certain defined cutoff of FFR, back then it was 0.75, it was safe to defer revascularization. I think that was the first notable piece of evidence. The second one was then the FAME study, directly comparing FFR-guided and angiographic-guided revascularization, which built the evidence that indeed FFR-guided revascularization is effective. And the last piece of evidence was the FAME2 study, which compared now an FFR-guided revascularization strategy versus medical therapy, guideline evidence-based medical therapy, and again showed a favorable outcome for the FFR-guided strategy. What I tried to say is that all these studies took a considerable amount of time, and as with any new technology, be it in pharmaceutical agent or be it in device or diagnostic procedure, it also takes time to be implemented in practice. Now, as it relates to your second question, the uptake in clinical practice, I would say yes, there is a slow uptake, but there has been a recent survey conducted by the European Association of Percutaneous Cardiovascular Interventions, which clearly established that during the past 5 years, there was a significant increase, both for diagnostic purposes at the time of coronary angiography, but also during percutaneous coronary interventions. And therefore, I'm very confident to say that probably with more time, it will find more acceptance in clinical practice. Yeah. And an obvious remaining hurdle is cost, because as anything, it requires an additional device, the pressure-tipped guiding, not guiding catheter, but guide wire, and therefore this may be a limitation in certain settings.
Yeah. So one is the cost, and second is the time consumed and third one is the hyperemic agents we use. So can we overcome some of these problems with something newer like IFR?
Yes, so I think the use of hyperemic agents, notably adenosine, is an important prerequisite to perform FFR, because the theoretical basis of FFR measures are to ensure maximal hyperemia, that is maximal vasodilatation of the microvasculature, in order to equate the myocardial blood flow to the coronary pressure measurements that are obtained. And therefore, adenosine is really the pharmaceutical agent that is used in order to ensure this maximal hyperemia. Now, what we have recognized is that this is also in a certain way in limitation, because it takes a certain period of time, not much, but nevertheless, interventional cardiologists are usually inpatient species, and therefore this is one limitation. The second one is that a certain proportion of patients also experiences adverse events, and that lead perhaps to a premature interruption of the adenosine. And in this context, during the past few years, there has been the advent of instantaneous wave-free ratio as a concept to use something which is analogous to FFR, that is the assessment of pressure differential during the wave-free period during diastole. And that obviates the need of vasodilator substances like adenosine. And indeed, the body of evidence that has been accrued is very favorable for instantaneous wave-free ratio assessment of physiology.
That's right. Coming back to FFR, which we still use it, do you have any preference for using other hyperemic agents? For example, we have papaverine, we have nitroprusside. Are they better than adenosine, or adenosine is the best?
I think in my personal environment, we are using adenosine, and this has a rapid onset. It is rapidly reversible when you stop the agents. It's easy to administer. And I think the important thing is that you have a standardized setup in the catheterization laboratory that ensures that you can administer or ensure maximal hyperemia in a reproducible setting.
So comparing FFR versus IFR, apart from the disadvantages you mentioned with FFR, are they equal, or is IFR non-inferior, or is it superior to FFR?
I think that's an evolving issue and subject to intense scientific scrutiny and studies. But importantly, there have been two recent prominent studies published in the New England Journal of Medicine, notably one study coming out of the Sweetheart, and the second study referred to as Define Flare. And I think both studies established that actually IFR was non-inferior to FFR. And in the context of the limitations we have mentioned before, that is certainly a strong consideration to further establish IFR in the clinical environment. Now, I think nevertheless, everything needs its time to find a maturity, and what I mentioned before, the body of evidence that has been built around FFR is rapidly building around IFR. But an important study that certainly is missing at this point in time is an IFR-guided revascularization strategy as compared to medical therapy.
That's right. And so in this transition, there are a few labs where I also involved to some extent, was you do this hybrid approach. You do IFR, the doubt, gray zone, then you go to FFR, you get a value. So if you got two different values, different values, which one were you going to choose?
Well, I think the hybrid approach has been used at a time where the confidence in the IFR measurements was still a subject of debate. And in a gray zone area, anywhere between 0.83 and 0.93, you would then verify the value with FFR measurements. But I must say, with the recent advent of the defined flare and the Sweetheart study, this is no longer necessary. So the IFR cutoff of 0.89 could be accepted and obviate the need for a hybrid approach.
Yeah. So coming back to FFR, IFR, which are non-invasive methods, there is a CT-guided FFR, which is non-invasive method. How does it compare with these two?
Well, I think we do have only limited experience with CT-derived FFR. Actually, the algorithms actually could be also derived during the time of coronary angiography. I think there has been an initial set of studies that are rather encouraging. But I think the invasive correlation of CT-derived FFR with invasive assessment, either of FFR and IFR, certainly requires further scrutiny. And I think this is the interplay of two techniques. First, we also know that CT angiography is very good and precise in ruling out significant disease, but that there is a certain gray zone when it comes to intermediate or high-grade stenosis, where actually coronary angiography remains the standard of care. And I think we still need to learn more then about CT-derived FFR and invasively derived FFR in analogy to CT angiography and coronary angiography.
That's right. And do you see any problems in using FFR in the cath lab? For example, left main disease. Are there any special problems?
So left main disease is a challenging lesion for both angiographic assessment, but also physiology assessment. I think since the early days of coronary angiography, it has been recognized that intermediate left main stenoses are difficult to assess. And this really led to the advent of intercoronary imaging, where actually we have very reasonable data as it relates to intravascular ultrasound to provide us with more diagnostic accuracy. Now, there have been studies performed using FFR, and these studies certainly are helpful, but I think the practical aspects need to be taken in consideration, because usually what we need is a good calibration of the aortic or proximal pressure measurement relative to the distal pressure measurement. And in left main lesions, this requires disengagement of the guiding catheter from the coronary artery tree. And usually what you are required is to advance the pressure-tipped guiding catheter into the coronary artery. So the equilibration of the pressure-tipped guide wire is a challenge. The second one is that left main disease may not be isolated disease, but it may come with disease more downstream, be it in the left anterior descending artery or even more complicating in the left circumflex artery. And the contribution of these various lesions then to the hemodynamic relevance of the left main lesion is a challenge, a diagnostic challenge. But there are ongoing studies, and I'm sure we will find ways how to further delineate this in the future. Equally important will be the role of optical coherence tomography as compared to intravascular ultrasound in the overall assessment.
IFR also will score over FFR when there are tandem lesions or diffuse arterial lesions. Is that right?
Yes, so if you have more than one lesion, certainly one way to assess these lesions is to do a pullback during maximal hyperemia, which then provides further diagnostic information as to the relevance or the hemodynamic significance of one versus the other lesion. And I think this is an important additional assessment beyond the coronary angiography estimate.
So you can sort of you can study the whole coronary artery physiology and co-register with the images, and you do virtual PCI with this?
Yes.
New advances in
Yes,
this?
so this is one opportunity we have in patients with multiple lesions, and it is certainly an additional feature to improve our diagnostic accuracy in appropriately identifying those lesions that require revascularization.
Do you have any sort of reservations about doing this in acute coronary syndrome setting? Because basically it does assess the microvascular pressures and function. And in place of acute coronary, for example, you're doing primary PCI, and there's another lesion of intermediate coronary nature. So will this assessment be accurate?
So this is a very good question. It's actually a frequent encounter we have. Then in up to 50% of patients that present with an acute coronary syndromes, you may have, beyond the culprit lesion, other lesions that may or may not require revascularization. Now first, as it relates to the culprit lesion, I think we still rely on coronary angiography, which typically identifies either an occluded vessel or a lesion that is easily appreciated and identified on coronary angiography. However, then the question arises, what other lesions need to be revascularized? And I think what we do appreciate is that patients who have more lesions have worse prognosis. The more difficult question is how we can improve that prognosis and whether revascularization beyond medical therapy adds therapeutic value. Now, there have been sets of studies both using coronary angiography estimates of coronary stenosis as well as FFR-guided revascularization strategies in patients with acute coronary syndromes, and both indicate that actually early revascularization may be beneficial. But one has to recognize that these studies are limited in patient population, and I think a definitive answer we are still missing at this point in time. So to answer your question, I think it remains an important open question, and I think at this point in time we still do not know whether physiology-guided revascularization versus more coronary artery stenosis severity, or what I would refer to biological activity of stenosis, plays an important role. Because I think in acute coronary syndromes, what we have come to recognize is that these are typically pan-arteritis phenomena where more than one lesion may be prone to plaque rupture, and whether physiology as compared to, let's say, imaging-based strategies like optical coherence tomography are the best strategy, we don't know at this point in time.
And before I come to my last question, I also would like to mention even Grunzig thought of this when he started his interventions. He tried to measure the transstenotic gradient with his fluid-filled catheter system, but that had problems. So my last question is about the question of using this FFR in patients of acute myocardial, going for post-CABG, or decide on bypass surgery. Can you select the patients for
Yes.
CABG?
Yes, so that's again another very interesting question, and indeed there are ongoing studies to use FFR in order to determine the need for coronary artery bypass surgery, comparing a strategy of conventional angiography-based referral to coronary artery bypass surgery vis-a-vis an approach where you use FFR guidance to basically reclassify lesions that are significant or not. I think at this point in time it's premature to make a firm recommendation, but certainly if we apply the concept of physiology-based revascularization to PCI, it would also make sense to apply this approach to coronary artery bypass surgery. But I think we need more time in order to await the results of those studies.
I have an additional question on, now that you're interested in TAVR, right? So severe aortic stenosis, TAVR, what is its impact on FFR?
Yeah, so I think we have to recognize that usually severe aortic stenosis is the leading problem in patients with aortic stenosis and coronary artery disease. So our strategy is usually to first treat the aortic stenosis and then to reassess the significance of coronary artery disease. We do know that patients who have both coronary artery disease and aortic stenosis have worse prognosis as compared to patients with only aortic stenosis, but the strategy as to the best therapy, whether this is a conservative approach or medical-based approach or revascularization, still is open and requires further study.
Yeah. But I seem to have read some reports where after TAVR, it might unmask some of the lesions in coronary artery when you do the FFR.
Yes, it may, but I think it's premature to make a firm conclusion. Yeah.
So I thank you very much for your answers to some of our questions, and it's been a great pleasure to interacting with you, Professor Stephan.
Thank you very much. It was a pleasure to be a guest here. Thank you.